Welcome back to the Barbell Therapy Podcast. I am your host, Dr. Brett Scott, and today I have an old friend and a colleague of mine, Dr. Will Mills, with me today.
What's
And
up?
so a little background. Me and Will, it's been quite a few years now that we've been friends here since we ever did Level Up together. So we went through that, and then I had started my cash practice a little bit before Will had. And so I've seen him go from master memeologist to to cash practice business owner. Are you guys out of network now too?
Yeah.
Yeah.
Yeah, we've been out of network for the past year.
Yeah. So Will actually has an interesting background though, and I'm actually very excited about this podcast today because Will has gotten himself into quite a bit with men's health, prostate health, and pelvic health. And I really haven't heard much about this. So I had a lot of questions I wanted to talk about today. And then we'll end that off with some of the common frustrations we're having with the movement profession industry as a whole and what we're seeing and how it differs from what we might actually need to be doing. So, Will, give us a little background on yourself and kind of how you got to where you are with the whole pelvic and prostate and men's health thing.
You want the origin story?
Yeah, give me the origin story because I don't even know that much about it.
Yeah. So the thing that roped me into it, like it was not on my radar at all. Like if you would have told me that I would be doing that whenever I was in school, I probably would have laughed at you. Because it was full steam ahead mindset wise in school for like my ultimate goal is to work with CrossFitters all day. And I was actually just having this thought now that I'm making my triumphant return to posting on the internet. On Friday, we're going to be posting about like my patient that I currently have. His name's Bob. He's given me leeway to talk out loud about him. He's not a prostate patient, but he's the epitome of why I got into cash practice and what I wanted to do, in the sense of like the thing that drew me into the CrossFit and CrossFit community, then weightlifting, was the fact that anybody can do it and it's scalable across the lifespan. And I saw Bob yesterday, and Bob was like a fall risk to the nines. He had all these balance issues. He went as far as to get like a brain stent put in the hopes that it would change like his CSF fluid, and didn't really do shit. He was in hospital balance vestibular rehab for 3 months. Nothing happened. He was such a fall risk that his wife with Parkinson's couldn't take care of him, so he moved down to Baton Rouge because that's where his family is. And he's my gym owner's grandpa, and they were basically like, could you try to help him? And then I assessed him and I was like, look, Bob, you got a lot of shit going on, but if you're willing to put in the effort, I can get you where you want to go. And he was falling like 2 or 3 times a week. And we've gotten him to the point where he's walking 3,000 plus steps a day with a single point cane, and he's pretty damn independent. All that to be said, that's what got me into the idea of I want to do a cash practice and be in the CrossFit space, because I knew I was going to be able to work with people that want to snatch 3 wheels and bobs. And the same principles of lifting and strength and conditioning and all this stuff that we know is effective applied to that. So that was my mindset getting out of school. And it wasn't until I went to CSM in New Orleans that my other friend, who's a gym owner here in Baton Rouge that I treat out of at Iron Tribe, wanted me to meet a pelvic therapist that went to his gym. So I met with her at CSM. She told me about how the pelvic health side of our profession needs more men, um, men who treat men and have the same parts as guys that are having problems. Um, so she basically offered me a job and mentorship. So I started with her when I initially moved back to Baton Rouge. Once I had graduated and did a travel contract in North Carolina, just because I was basically delaying the inevitable. So I started working with her, and the mentorship didn't necessarily go at the speed that I wanted it to, and she had a lot of different things going on with her business and having a kid at the time. So I decided to step away and just start my own thing. But I knew that I didn't want to stop doing pelvic health, so I kept doing it. Um, it was kind of like it kind of started as a word of mouth thing. Like I had a friend who was a dentist, and his friend had just had a surgery, and he was peeing all over himself. Um, so, so just kind of background of that guy gets diagnosed with prostate cancer. They opt for either a radical prostatectomy, so removal, or radiation. So more often than not, surgery is happening at this point because radiation is just not as done as much. So he gets surgery. I start seeing him, start having good results, and then it kind of just started to bloom from there slowly. Like I didn't really push it. Um, so you know, in that space, you're initially working on urinary incontinence. So the guy is struggling with urination like pretty consistently. Like it's like a dribble. I call it the soaker hose effect. Like when they first have surgery and first get their catheter removed, there's just like no control, right? So when the prostate gets removed, you have a sphincter that's around your urethra, and that gets removed, and it's a lot like postpartum in the sense of like there was a trauma to your pelvic floor area, and now you have to retrain the pelvic floor muscles to make up the difference. So in that space, it's like there's a lot of education, there's a lot of bowel, bladder, and sex habits to talk about. There's a lot of structuring somebody's day, helping them structure their day surrounding like when they need to be doing their exercises, how they need to be doing their exercises, how they're applying their exercises to their daily life. It's a pretty common soapbox that I get on about like if you look at the idea of doing a Kegel as um, just doing an exercise that's going to help you get better, but you don't actually apply the principle of like, okay, is this an endurance Kegel? Is this a quick, what we call a quick flick, like fast turn on, like you're about to do something quickly and there's speed and power? Is this an endurance Kegel? Are you going on a 40-minute walk? Are you going on a 100-meter, 35-pound farmer's carry? The endurance side of that Kegel, like 20 plus seconds, might be very different if you're going on a body weight walk and it's like 10% contraction for 40 minutes or trying to maintain that versus, you know, you're at 10% before you pick up the weight. You got to bump it up to 60%. You got to hold that. You got to be mindful of your breathing. You need to not bear down. Like a lot of older dudes, this is like 55 to 75 age range. A lot of them have like long history of low back pain, maybe long history of hip and knee pain. they play golf, they play tennis. It turns into like an orthopedic case on top of a pelvic case. So you get to use a lot of the same principles. And when it comes to training the pelvic floor, I do it very similarly to how I would do most things with like stability training of the pelvis or the low back, in the sense of, you know, front and back first, side to side second, rotational third, and then there's so many different nuances in between. Um, but it's mostly helping someone manage their intra-abdominal pressure and be able to match the pressure that they are producing with a lift of the pelvic floor, and then sequencing surrounding that, and then um, loading it. So it's very similar to everything else that people are doing. It's just a very different flavor and process and a pretty specific demographic of who's having it. Like I said, 55 to 75 range.
And so let's just go back for a second because I think there might be a lot of trainers and people out there listening that maybe working with this population and don't really know it because maybe they haven't had the conversation or the patient
Yeah.
hasn't had it. But talking about intra-abdominal pressure and things, so just for people to understand is basically the way the pelvic floor works and the musculature down there works for us to be able to hold in our urine and such and our
And
poop
bowels.
and our bowels. When we go to lift anything or we move or we go to run, anything that's kind of a higher level task, even walking is a low level task, but at these higher level tasks, our core and our abdomen is going to fire up and create pressure within our abdominal cavity there. And that pushes on the bottom floor or the pelvic floor.
Mm-hmm.
And if there's too much pressure where those are things like our sphincters and our pelvic floor musculature isn't strong enough or isn't working properly, we will pee or poop ourselves.
Yeah.
And so that's kind of what Will's talking about there as far as that goes. So now, Will, is there a lot you're doing? Is most of it with has to do with prostate cancer and prostatectomies, or is there other things too that you're seeing in this field of uh, non-oncology type patients or non-cancer patients?
Yeah, I see pelvic pain. Like pelvic pain is another common but not as common diagnosis. Pelvic pain can, you know, it could range from a 15-year-old to a sky's the limit past that with age. Like pelvic pain can affect any male that has hit puberty, really. I've had I've consulted a guy who's like 18 and it started when he was 16. Um, the thing about pelvic pain is kind of like it's one of those diagnoses where they typically get a diagnosis and they're just sent home and told them and told to, like, you know, try these antibiotics. They're usually given the diagnosis of prostatitis, so like an inflammatory response of the prostate due to an infection. The higher end research shows that like as little as three, between 1% and 3%, if you do the more expensive biopsy test, actually have an infection to warrant um, antibiotics. But most guys, because it's easier, get put on that, and it usually makes their symptoms a little better for about a week, and then everything gets worse. So a lot of these guys have chronic pain for. It's very unfortunate that like the majority of the guys that I see, it's like they've been dealing with this for 15 to 20 years, and it's like I have to pull them out of the seventh ring of Hades, um, to to get them out of just constant chronic pain. And there's so many things from a lifestyle, physiological changes, all these things that, you know, they don't want to exercise because everything hurts. But the fact that they don't exercise makes everything worse. But they don't get that. So you have to like find these little ends. It's a lot of education. Um, and it's usually not necessarily the prostate's fault. It's just something happened at the lumbar spine, something happened at the hip. There's a lot of different systems feeding into it. Hurts when I sit, it hurts when I get an erection, it hurts. You have something to say.
Yeah. Yeah, I want to cut. You just started to go on it, but
Yeah.
I actually, so I'm lucky. I have a good affiliate down the road from us. So pelvic pain and rehab centers. So if anyone's looking for something there, that's who would we I would refer you guys to. But um, I work a lot with women, so they get to 80%, or this pelvic pain and rehab specialist, they'll get people or patients to about 80%. And then, like, if they want to go back to running or anything, they'll come to me and I kind of finish the job and get them to that 100%.
Yeah.
Now, there's been plenty of cases, and I'm seeing it more and more now. The more I'm becoming aware of my own assessment skills and really learning what's what. But quite a bit of people have low back pain, hip pain. They'll go to the doctors. They'll go to an orthopedic. They're told, oh, it's just tendonitis. It's hip pain. You have tight glutes, whatever. Um, and then they'll come to me, and the signs don't always add up. And we'll try a couple different things, and then it's like 2-3 sessions in, it's like you're not responding. Um, and so then we'll start asking these questions,
Mm-hmm.
and a lot of times, like, oh, like I didn't think that was related. So a lot of people don't even know that some issues they might be having at home aren't related at all,
Oh,
or are completely related to their back pain or their hip pain or their groin pain.
yeah.
And I just want to make people more aware of this stuff, that it's becoming more and more common as we're seeing it, as we just start to talk about these issues and topics more. But what, from a provider standpoint, for us, it's like sometimes they'll come to us too, and they don't get better because we're not seeing the full picture. It's like we see the tip of the iceberg of, okay, maybe they have some decreased function here and here, but they don't respond to treatment. And then they end up just leaving treatment and not knowing what's wrong. And they go on with this pain for years. Where what things, specifically, let's talk more about men, but even women, but what things or what issues can people have at home? You started to allude to it, that could be responsible, or the pelvic floor is responsible for, and some, lack of
Yeah.
function that could be
Yeah.
causing problems.
So, so something that I talk with everybody about is water, how much you're drinking on a daily basis, and fiber. And it's like if I were to just, preface a conversation with a patient of, okay, with any pelvic floor issue, I'm I always talk about the three big buckets. And I wanted to say this earlier whenever you were talking about the intra-abdominal pressures. I usually preface that with, I view it as like the canister or the can effect, where it's like we have to consider which part of your can is the problematic part. And with a lot of these older dudes, they also have a history of hernias. They have a history of diastasis recti. I've seen huge diastasis recti in dudes where they have, for all intents and purposes, a big split down their six pack muscles. And basically, when they, do a sit up, do something that increases their pressures, they're basically bulging their organs out. And that is no bueno when it comes to dealing with pressures. But we could go back to that. So, um, with crap, what was the question? Sorry, I'm a squirrel.
It was, what things could men or
Oh yeah,
women
yeah,
be
yeah,
dealing with that are symptoms of a pelvic floor issue that maybe is not completely
yeah. They're
known
not
to
totally aware.
medical providers.
Yeah, or even themselves, because that's something that's like when we get into those three buckets: bowel function, bladder function, sexual health, and then function. So there's like a third, but then there's the fourth of just like how you move on a daily basis. Um, Water intake and bladder habits and pooping habits, like two like big heavy hitters in dealing with this issue, in the sense of, people sometimes don't even realize that they have an issue with, like, they think it's normal that they go to pee every hour, or they try to poop 5 times a day, and they feel like they don't fully evacuate, but you know they just keep doing it because that's what their body's telling them. And it's very similar to pain, where it's like, just because you have that initial sensation of, oh, I need to pee, oh, I need to poop, doesn't necessarily mean it's time. And if you continuously do it over a long period of time, you can basically change your body's ability to understand what these signals or cues mean, or boil it down to a reflex, where you're creating a poor habit. And in the sense of where the symptoms lie, it typically ends up with, you've been doing this for 5 years, you've been constipated, you didn't think you were constipated. Upon further inspection of what your poop looks like, when you actually like give someone a sheet and it's like 6 different types of poop, and they're like, oh yeah, I'm that one, and it's like, that's a sign of chronic constipation. Um, if you're chronically constipated, your bowels are having to work harder. You're having to work harder to evacuate. You're having to use pressures that you shouldn't necessarily be using for every single time you poop, to get it out and to initiate. And that typically, you know, it makes your pelvic floor have to work harder. And eventually, there's going to be some changes to the pelvic floor. It's not going to continue to work as well or effectively. And it's like the traps and like neck pain over the course of a day. Like, they just start to get beat up, and then they start talking to you, but it's not as evident because it's in the pelvis, and people don't typically go there first. It's usually like a further down the road thing. Um, but from like a subjective screening standpoint, water intake, bowel and bladder habits, like frequency, duration, getting into those conversations, like, it's good conversations to have, as far as screening purposes go, for sure.
So, so like some of the things I've seen that I unfortunately didn't catch right off the bat, because again, these things aren't all that common, but they're becoming more common. The more I practice, and the more I see them.
Hmm.
Um, but a few of the things I've had one guy that he was getting up 8 times a night to go to the bathroom. I've had
Okay.
another guy that told me he couldn't. These were all back pain cases or hip pain cases,
Hmm.
and they just weren't responding to treatment. And so I started asking more questions, and I went to pelvic floor type things. And I am no expert in pelvic floor, but I at least know to screen for it and to call out a red flag and say, I need to
Yeah.
refer you to someone else. But it was, yeah, peeing, basically hourly, not feeling like they could empty themselves. I've had a couple men now, young men too, that felt like they couldn't hold an erection for more than 5 minutes, and like they didn't have endurance down there.
Yeah.
So, what other things could we see that like don't seem like something related to back pain that could definitely be related to pelvic floor?
You hit a lot of common ones, actually. Urinary infrequency, um, sensations of, oh, I have to pee, heavy urgency, like, oh, I need to pee, and if I don't sprint to the toilet, I feel like I'm gonna pee on myself. Those are all like, those are all things that can be heavily related to habits, and like, when those things start to happen, there's typically a side of, well, I don't feel like I fully empty, therefore I have to push to pee. You should never have to push to pee. If you're pushing to pee, something's happening that shouldn't be happening, and that could be like a screening tool of it in and of itself. You ask the question, do you have to push to pee ever? There could be something that's, blaringly pelvic floor related. But pushing to pee isn't necessarily like a thing or like a diagnosis. It's more of like something that is a outward expression of their symptoms, and it's something that could allude you to, oh, they probably need more help. But then they start to think that it's normal to have to do that, and that's like one of those things. um, in the weightlifting community, with females peeing on themselves standing up a heavy front squat
Completely
is
normal.
pretty common. um, Heavy deadlift, that doesn't really happen as much in the dude life. But like squat farts are pretty common. And that goes in. Okay, so this is a good bridge. This is a good bridge actually for me to get on my prostate soapbox of like, so what I see with prostate guys, right? What we had talked about previously. You got to unpack the demographic. These older dudes typically have long history of low back pain, hip pain, knee pain. A lot of them, they want to get back to being able to travel without peeing. They don't necessarily have exercise goals. I'm in South Louisiana. Most of them are overweight because, laissez bon temps rouler, like, let the good times roll. And it's Mardi Gras season. So it's like most season, like football season, go Tigers, rolls into Mardi Gras season. So like most of the years surrounding like, hey, let's party, and the food's good down here. So like most of these guys kind of overweight, don't have a good history of nutrition, and they have the diastasis. They have these things. They have these history this long history of hernia repairs. So if movement doesn't matter, and the idea that's getting perpetuated on the internet of just pick the fucking bar up, it doesn't matter how you do it, like doesn't matter how you preset, doesn't matter how you breathe, bracing is good, push all your innards out, put that belt on, just fucking belly breath into it, don't use any kind of strategy. Like if we're encouraging that for powerlifting and barbell stuff, I don't know. I don't know what's going to happen. Like, there's not a long term research study on like what's going to happen from that. But I see these dudes that don't have a history of lifting correctly, and they think that they've been doing it correctly for the longest time. And I do, an abdominal assessment and a pelvic assessment, and I say, okay, do a Kegel, and everything's just bearing down. So I'm like, oh, so you've been lifting like that for the past 30 years. Like you go to pick something up and you just bear down. That's not really good for your abdomen. That's not really good for your pelvic floor. This is probably why you've had hernias. And there's not like, I don't feel the need to like self-assess in the sense of, oh yeah, you've had 3 hernia repairs. Do you just keep picking up the fucking thing? Just pick it up. I don't give a shit.
So, so this is a great topic, and this is a great bridge here into this conversation. So again, a little background on this, but I think it's been
Breathing and bracing.
a f-
It's an important thing.
it's been a really frustrating topic to see on the internet, I think, for me and Will here. And we've kind of gone through it together. We graduated school at the same time, and a lot of people now know about pain science and how important pain science is. And it's like, I remember coming out of school and being like, what the fuck is what? Like, we learned all this manual therapy and biomechanics and biomedical model in school. And then you come out and you start listening to these other guys that are saying, oh, biomechanics don't matter. It's all about pain science and everything's in your head. And, it's just sensitive X, Y, Z. and nothing really matters. We just need to, calm it down and then build it back up, and you'll be fine.
Yeah.
And
And that was like I don't want that to come across as like everybody was saying that, but like that was
the theme.
the theme, that was the messaging. But yeah, go ahead.
And I know for myself, I love manual therapy. I'm a huge believer in it, a proponent of it.
Same.
Not by itself, but even just being in the performance model of being a weightlifting coach. It's like form fucking matters.
Yeah.
It does. You can't have a really good elite level lifter and not worry about technique.
Right.
So that was one of my pieces there, and
And
teaching people to
that's the
deadlift.
lens. That's the lens that like I was a CrossFit and weightlifting coach before I went to PT school. So like learning open and closed pack shoulder, like I was like, okay, so it's like the snatch. So like this is closed pack position. Like I I I view things through the lens of how does this relate to what somebody would expect with hinging to pick up a bar and either getting in a clean position or a deadlift position, and then where does it go from there?
and and so we go through school and we learn this, and I definitely changed my tune of understanding pain science and respecting the laws of it
Right,
and our communication skills with people, but it just still didn't make sense to me, and it still doesn't. And there's still plenty of people out there on the internet trolling other providers for talking about good form and good technique. And now I've gone through a residency program, and a manual therapist in orthopedic manual therapy resident, a fellow in PNF. So shout out to my boy Ramez from Neuropedics here. Has done both. So he's seen the neuro, he's seen the ortho, he's followed the pain science, and he really taught me that all of this can live together in the same place. And we still need to respect biomechanics, because I've had so many complex cases come in now where biomechanics did matter. And so much of this comes down to low back pain, um, could be pelvic floor, just breathing dysfunction, bracing dysfunction, things that we really need to improve upon, that just some of these people out there now, it's just like, nope, just keep going and loading it and doing whatever, and it'll get better. When
right.
I think the pelvic floor in these things really shine light on, hey,
It's instant
pressure.
feedback. If you don't do it right, you're gonna piss on yourself. Like I have a very unique view of this because I'm the only one doing it with dudes as a dude, but it's like A plus B equals C in
And
this instance. Like if you don't do it right, you're gonna have the instant feedback. Oh, I peed on myself. Oh, I felt a little dribble. Oh, yep, it was a squirt. Like I hear dudes say this to me all day, and I said, "What happened? Did you not fully exhale first? Did you not get all your pressure out first?" Like that's my mantra with building somebody back up. Is like, yes, we have to learn. You're going to have to learn how to exhale, create a cinch, and then breathe into that cinch to support everything. Like using your breath, right? But until you've learned to lift the pelvic floor to match that pressure of the breath, so it's like things like butt up against each other and do that symbiotically rather than you just pushing straight down or pushing straight out, then we're training, let's try to get as much pressure off of your bladder as we can. And like the process and the sequence of that very much matters. The science behind like what is the optimal Kegel for a dude, it's front to back. It's retract the penis, lift the testicles, butthole to belly button. Like that's what I say, right? And if you do it from back to front, it's not as effective. So like that matters. I mean, I could argue all day like how much biomechanics matter and how they shouldn't be written off. That's not to say like I I don't tell people, oh, you have this issue, so you shouldn't pick stuff up. Like you should never like lift something off the ground right now. It's like no, it's yeah. If you don't manage your pressure well, right now, you should expect to pee on yourself. You should expect to have some leakage, right? If, and whenever I'm not just saying off the cuff, oh yeah, dude, you're peeing on yourself. It's like, no, like we have the conversation. Do you want to speak about this in anatomical terms? Do you want me to say incontinence? Or do you want me to just say you're peeing on yourself? And they're like, yeah, let's just say peeing or pooping or an erection. Like, do we have to call it the perineum? No, we could just call it the gooch. Like, you're cool with that, right? Yeah. All right, cool.
Boner talk.
We're going to call it the gooch. Um, and these things, there is like it is as much the habits as the biomechanics. I tell guys on the first visit when they're coming in to do a pre-op, and I would say for prostate cancer related things, it is as much habits as it is biomechanics. For pelvic pain, it's a little different. Still heavily involved with biomechanics. Big big things related to pelvic pain with where the thoracic spine meets the lumbar spine, the lower lumbar, how the pelvis moves, how the pelvis stabilizes. Um, I haven't had a pelvic pain patient that didn't have a lot of orthopedic things also going on. And in most of those cases, because pelvic floor therapy is a little bit more invasive, on my initial screens, like, I'm saying, what's your goal here? Like, I still want to be able to play volleyball when I have this, as I'm having this issue, but I don't want it to constantly flare up. All right, well, let's start with your low back and your hips, because pelvic floor is secondary if you're trying to play volleyball and not piss everything off. So it's okay to start with the orthopedics and work your way down the chain into the pelvic bowl. But it's just one of those things where you can't totally write off the biomechanics, and biomechanics do matter in that instance.
And so, do you think, Will, because I don't know, but you probably have better insight into this, of the population you work with definitely shines light on how much biomechanics can matter and do matter, especially for it. And I see it too as a powerlifting coach of, if I can teach someone really to lock down and bear down on their core and get things set right, like the squat looks better, their positioning looks way better, and a lot of them feel more powerful. And
Right.
some of it doesn't take much more, and people shit on McGill all the time, and that's fine. But like McGill Big Three works, like hands down. Like, I've had so many lifters come through in injury and not an injury, just for performance, and I have them do McGill Big Three for like 2 months, and all of a sudden it's like they really just learn to feel where their abdominal pressure should be and needs to be, and they learn to lock that in.
Yeah.
It's a positional isometric, and then all of a sudden, like, their squat goes up 20 pounds, and we didn't change anything.
Yeah.
But do you think so? So there is this whole culture of just load it and do it however, and just pick up the bar however you feel is best. Do you think there is some long term effect this might have on people?
Of not doing that, like of just picking up the bar all willy nilly.
Yeah, just no regards for position or anything. Just pick it up how they feel is necessary. Do you think there's implications to that later on for them, as far as not only orthopedics but for pelvic floor type issues?
Yeah.
Because it's a thing in powerlifting too, to blow an O ring.
Yeah. Well, so if you have any ideations of wanting to get better at cleaning and snatching, you're going to be shit out of luck if you don't focus on how you lift it. For powerlifting, yeah, I have a good working relationship with a strongman gym, and I've done a podcast with them talking about, like, is it beneficial? Is it or is it not beneficial to use a squat plug? And I'm like, no, absolutely not. Like, please never even consider that. Your muscles are supposed to be able to do that on their own volition, and you should have an awareness surrounding that.
Was this an actual question?
It was like a half joke,
Okay. I was just
but I
like,
talked about like the mechanical tension curve and like why having a squat plug wouldn't be beneficial.
all
um,
right.
just because I'm a nerd and I had to. Um, the I mean, yeah, it's the amount of hernias that me and my business partner Joey have seen in powerlifters, dude powerlifters, is nuts. The amount of like the farts is nuts, and that's kind of like the young man's pelvic. Uh, I guess you could say pelvic insufficiency issue in the sense of if we're considering the canister and you're farting whenever you have heavy weight that you're moving, then you need to be able to match the pressure that you're producing in your abdomen with a butthole to belly button lift and lock it in, right? It's not mechanically advantageous to leak pressures, actually leak them out of your beehole while you're squatting or deadlifting heavy because something is changing. It's kind of like I would view that as like if you're using a velcro belt and like you're in the bottom of the hole and the belt unvelcros, like that's a really shitty feeling.
Hmm.
And it's like you there was just an instant change in pressure and how you got set. It's the same thing if you fart. Like the there's a pressure change
There's a
and
leak.
there's a leak. And it's not, I mean, right now it's kind of like, oh yeah, he farted. And it's kind of funny, but like it's surely not optimal. And if you unpack that and start talking to the dudes about like their bowel habits, like chances are they might have a hemorrhoid, they might have a history of hernia, they might have some upper groin pain, um, they might wipe entirely too much, they might have a very strange poop schedule, they might be going to the bathroom to pee way more than they should. Like those aren't outside of the realm of possibility because I've had powerlifter dudes that had those issues associated with it. And a lot for them, a lot of it was education. A lot of it was, you know, pelvic floor function independent of what's happening uh, whenever they're lifting. But it's one of those things where historically in the medical community, it's like, well, if I have these problems and I go to a doctor, they're just going to tell me to stop lifting. So I just don't, but I just keep farting or peeing on myself. When I do it, let's just keep sending it, baby. Like, load it up. It's probably not ideal.
Yeah, absolutely. And so, what are some things people can do as kind of a place to start helping themselves? And I know the issues with this question are you could be in two different directions too. Like with the pelvic floor, we could have hypertonicity or we could have hypotonicity. So some people need to learn to be more relaxed and some need to learn to contract better. So
Yeah.
aside from that, what are some things people should keep in mind? Where should they try to start looking for help? What's their starting point, and what things can they do for themselves?
That's if they don't have a blaring issue right now.
Yeah, if they're listening to this podcast, it's like, oh man, I have this actually sounds like me. Like
Yeah.
like I didn't know it wasn't normal to go to the bathroom every hour.
Yeah. I would say if those things pop up from like a habit standpoint, that would be like a yellow flag. Like maybe further investigation would be helpful. And I would say if those things are happening currently and have been happening, it would probably be helpful to consult a pelvic floor PT. Um, and if your goal is to lift, consulting a pelvic floor PT with the intent of I also want to keep lifting at a high level and improving that, not just I want to not. Um, the I would say that would be the most helpful as like a self assessment, just based off of the subjective. If those things are happening, it would probably help your performance as well if you got an assessment, talked to somebody, kind of screened it out, see what happens, and then maybe change a few things surrounding that. It's not it's not one of those things where it's like the idea is doom and gloom in the sense of, oh yeah, you're probably going to have hemorrhoids in 10 years if you don't work on these things. It's like, do you really want to not be comfortable when you have to poop every day? Like, do you want to feel like your life surrounds when's the next time you're going to the toilet? Like I had wings for on Sunday for the Super Bowl, and yesterday I was just like, I had to pee every 90 minutes because I ate a bunch of spicy food, and spicy food can piss off your bowels and your bladder. So I was like, I felt like I had these strong urges to pee all day. It was awful, and I was like, you know, if this was my everyday, I would certainly be seeking out help. There's people that do it for years and don't even know it's a problem.
Well, I think it gets progressively worse too over time, and it's just like that
It
slow change
definitely
of
does.
like someone can change weight and either go up or go down a weight, and they don't see it themselves, and all of a sudden it's like, wait, this isn't normal. So what would you define as normal? So for bowel and bladder movements, what is the norm for most people? How many times should we poop a day, and how many times should we pee?
So based off of it's a weird thing because it's like based off of the GI recommendations, it's considered normal to poop once every 2 to 3 days. And I'm like, I don't know how I would live. I feel like absolute trash if I travel and don't poop every day. Um,
Well, is that the norm or is that
it's considered
average?
normal.
Like
It's considered within
optimal?
reasonable. No, I wouldn't say so. I would argue the literal and figurative shit out of it's not optimal if you're pooping once every 3 days. Um, Once a day at the same time a day, like where
Machine.
you're a machine in the sense of you have trained your body to know if I do X, Y, and Z, I'm going to have the urge. My body's going to tell me that I'm having the urge, and I go and sit on the toilet, and I don't have to do much to get it out. And then I go about my business. Um, that's that is the most optimal in my opinion. Sometimes it's optimal for people to poop twice a day. Um, but then if it's like if you don't feel like you're fully evacuating or something along those lines, that might be a sign that you potentially have something going on with the pelvic floor. It's a pressurization thing. It's a reflex thing where you're not basing when you go off of the reflex. And then for urination, you I always say the rule of thumb is sleep is important, and I don't want to have to wake up to go to pee every single night. It is technically normal to have to wake up to pee once or twice a night. But if you have the capacity to be able to hold your pee for 4 hours during waking hours, you should be able to hypothetically hold it for 8 when you're sleeping. So it's like, what's the top end strength of your capacity of your bladder? If you can hold it for 4 hours, you should be able to sleep throughout the night. What is the average? Two and a half, every 2.5 hours, you're going to pee. If it's less than that, you might not be allowing your bladder to fully fill. And then that could cause like a diminishing returns thing, which is very common in dudes that are getting older as their prostate starts to get larger with aging. that kind of slippery slope is something that definitely happens and definitely should be taken into account. Um, but yeah, two
Can,
2.5 hours, pretty
can
normal.
people just train that though too to like just hold it longer? It's a muscle. It can be trained, right?
Yeah, so we talk in the clinic about want versus need. Um, the reflex of the initial sensation of, oh, I need to pee, might not mean that you actually need to pee. It might just mean that you've trained yourself to want to go immediately off the cuff of experiencing the sensation. So for bladder retraining, we say, okay, you feel the sensation that you need to pee. You're going to do a 10-second max contraction, max Kegel. For dudes, I say nuts to guts because that's the easiest one. Hold that for 10 seconds maximally, relax, and then check in with yourself. Do you feel like it's equally as strong? Do you feel like um, it's still there at the same rate? If it's still there and nothing's changed, you probably need a pee. If it's decreased sensation, then you should probably just try to wait another 30 minutes and see what happens. Um, for bowel function, the muscles are different. So if someone is having issues with frequency, like I've seen people that feel like they need to poop, they go to poop, they don't feel like they fully empty, and so they either stay on the toilet for way too long. Like you shouldn't really be spending more than 15 minutes on the toilet, um, because over time, like it is a stretch of the pelvic floor. It's probably one of the better stretches of the pelvic floor if you have like a tightness issue. Um, but that's a whole other conversation. But if if you are having a if you're trying to retrain the habit of needing to poop, um, going down the want versus need continuum, you would have to do a 60-second submax contraction. And a lot of times people don't know what a submax contraction is because it's
All or
like
nothing.
it's like SpongeBob at driver's ed. It's like just the big toe, not the freaking full gas it, right? Because most people just do that whenever you tell them to contract their pelvic floor. It's like, no, it's just a like 30 to 50% lift, and you're going to hold that for 60 seconds. So with the bowel stuff, it's a little bit harder to train because you have to teach the person, all right, this is what submaximal is. And then if they can't hold the submaximal for more than 15 seconds, then you need to do endurance training on top of that to get to the point where you can start to train the reflex. Um, the bowel stuff, bowel habit stuff, chronic constipation, it's something that is a little bit newer to me. I just took another Herman and Wallace class on learning about that stuff. Very interesting. A lot of psychosocial, habitual stuff plays into those things. And it's usually, as the therapist, you're like trying to reorganize how they do things to optimize those systems. And then that's where you're getting into the hydration and fiber conversation with people.
Well, yeah, and you still got a few more minutes here.
Mm-hmm.
Yeah, so that's one thing. So just even hearing you talk, so I actually for the past 2 years now was dealing with some issues of my own, and we'll just call them digestive. And what my I didn't even realize it either at the time, but I went to a functional medicine doctor, and they gave me the diagnosis of IBS, and I was like, what? And then just based on my subjective report and going back and looking at things, like, oh, like, yeah, I had urgency to go all the time. I had this. Turns out I had a parasitic infection, and
Sure.
they're still testing me for SIBO, which is small intestinal bacterial overgrowth. But we have recently cleared up the parasitic infection, which has made a big difference in my urgency to go to the bathroom, my frequency of going to the bathroom, my stools. And what I'm noticing too is, I had the squat farts far more frequently before, and I
Mm-hmm.
don't anymore.
Yeah.
And my squats hurt a lot less now than they used to because I was having like, anterior pelvic pain. I have FAI and or impingement syndrome in both my hips. I have bony overgrowths, but um, I didn't realize any of these things until they're gone. And it's like, oh, that was a big issue. And
Right.
even so, just digestive health. And so if someone's having issues in food sensitivities, bloating, constipation, because I got into this because I had a patient that was kind of in a similar boat and came in. She had SIBO, which basically wrecked her utilization of nutrients. She had stress fractures in both her femurs, and she had so much swelling in her abdomen by the end of the day,
Hmm.
and she like would look pregnant by the end of the day and like kind of skinny in the morning. She had a bunch of pelvic floor issues that she had addressed with another therapist and come to me. We still were on the mends of clearing up, but also I don't think people realize how much like digestive health and things matter too. So not only fiber, but like, and for me it was like, for me right now figuring out like my diet of like, not all fiber is optimal for you either. Like I'm on a low FODMAPs diet because certain fibers and sugars from carbohydrates will piss you off even more.
Yeah. Yeah. SIBO is an interesting beast. Um, Things that make people gassy is it's kind of like what what kind of testing have you had in the past? If these things check off, then we can then assume this. And for a lot of those people, it's like ball breathing and gut smashing, like getting on a deflated ball and doing a self bowel massage just to keep things moving because it's too difficult for your body to be able to do it on its own right now, and you just need to give it some extra help, or going on a walk like intermittently throughout the day so stuff's moving, you're like getting gravity into the picture, you're not just sitting. um, those things help manage those symptoms while you're also having like a team management strategy. And when it comes to digestive stuff, that's typically my triage is like, all right, what have you been told in the past? Has this been managed by another medical provider? Um, and where are you at right now? If those things haven't been answered, it's like, well, we should probably do that first, but we can also talk about your pelvic floor because that's like, it's kind of like the end of the pipeline, right? So
Literally.
yeah, literally.
So
All super important things for sure.
yeah,
But
absolutely.
the reintroduction of those fibers would probably be helpful for you to have like a sense of normalcy with you being able to eat things and not really worry about it. That's the side of it that I'm less clear on. Like, what are the time frames? Because I have a lot of people on FODMAP where it's just like they eat crackers and toast, and I'm like, that sounds so awful for like long term use, but they haven't really gotten an answer of like, okay, well, then we're going to start to do more inclusion of things.
Hmm.
Um, have you gotten into that?
Starting to. So I started with my functional medicine doctor in October, and so I currently have been. I didn't realize too I had like a pretty bad dairy allergy, so I eliminated that and noticed a big difference in my mind. I just like less negative thoughts, less anxious. It was weird, and I didn't never consider myself anxious. So I eliminated that. We did some food sensitivity testing, and we did a stool sample, and I am in like complete dysbiosis, so my bacteria are way off, and I had the parasite. And with the food sensitivities, it was I'm allergic to or sensitive to all dairy, eggs included. Um, I am good with all meats. I am gluten free. I am sensitive to yeast as well, apples, bananas, some other things. So, and then I had found even before that that the low FODMAP thing was definitely making me better and less symptomatic. So it's been this ride of, well, these things are working for me. Like a bland diet is the best thing for me, which
Yeah.
is no vegetables. But Um, it's hard because you also want nutrients, and
Right.
so it's this slow. So I've been doing the low FODMAPs thing, and then the thing about the SIBO is there are certain so FODMAP is kind of highly suggested for a lot of these people, and it works for a lot of people. But there's also there's two different types of SIBO. So there's methane and hydrogen, and so certain different foods will piss off the um, one respective type of SIBO and not the other. So it's we're doing the testing now to find out which type of SIBO I probably have. Um, but then it's just slowly reintroducing foods and seeing what works, because there's a lot of foods that are high FODMAP that are good for SIBO, for some types of SIBO, and
Hmm.
not for others. So yeah, it really is a mix of like doing this. But I found myself like last week, um, we had a meal, and it was like spinach and there was some garlic in it, and it was I did not have a good day the next 2 days. And I
Yeah.
was like, well, was it the spinach or was it the garlic? And it's like I don't want to eat either of them now. So you get this like
Right.
you there is this like psychosocial component to fear avoidance of food, because you don't want to have to deal with that for the next 2 days.
Yeah.
But
So I can't not tell the SIBO story that I have because you brought it up. I had this guy that I was consulting with who hadn't hadn't received his diagnosis of SIBO when he took it into his own hands to try to self treat. And he had read on the internet that SIBO doesn't like carrots, and so he ate a bag of carrots. And the night that he ate the bag of carrots, he had extreme gas for like 8 hours straight. And he said that he probably farted like 600 times. He spent the whole night on the toilet because he just felt like he was going to defecate at any time. He couldn't go to sleep. It was like one of the worst nights of his life. Um, so the ramification of that was like anytime he was doing something functional, he felt like he had the urge to go poop. And my hypothesis there was he farted so many times during the night of what we called carrot gate, um, that he created like a mechanical insufficiency of his external anal sphincter. So like he needed to do a butthole to belly button, like low grade butthole to belly button contraction when to re-educate those muscles to like work in a neutral range, because it felt like he had like a sagging type of sensation. Like he would describe it as like it feels like my butthole is hanging out, but he never had any rectal prolapse. He would feel this heaviness there. So the treatment there was okay. Well, let's talk about endurance. Let's talk about utilization of that muscle, and then we just need to apply it. It's going to feel weird at first, but we just need to apply that gentle lift to match what you're doing based off of the task. Go and walk around the park with your kid is different than doing 225 RDLs, right? But you need to be able to apply that contraction to based off what you're doing. But all of that happened because of SIBO and the night where he ate the carrots. Um, so it's always these stories are always interesting as far as like what happens to people and how the pelvic floor can turn into the symptom, not necessarily
the
the
source.
cause of what's happening, but like it's something that's now affecting their daily life and health, and they want to figure it out. So it's kind of like one of those things where it's you have to have both. You can't totally separate out the buckets, or it's not going to be successful. You have to take into consideration nutrition, how that affects the bowel health, how that affects your timing, how that affects what you're doing whenever you're lifting. I would say it's much easier in the cases of like a guy like him where he's already training and he hasn't stopped training because of this. but training is now problematic. Usually it's they haven't been they don't even consider themselves to be training or trained because they've completely avoided all kinds of physical activity because they feel like that. That's a whole other type of beast. So
Yeah. There's so many different rabbit holes we could go down here for
yeah,
sure.
yeah,
Um, but I do have to wrap up here because I have to get to the clinic to treat a patient. I think you do too.
yep.
So, Will, where can people find you?
So I'm on Instagram and Facebook as docmills.dpt. You can also find me on my clinic website, Alinea Performance. It's also Alinea Performance on Instagram and Facebook. Um, if you need to contact me, you can shoot me a DM, or if you go through the website, my email's on there. My email's in my bio on Instagram. But yeah, docmills.dpt and then Alinea Performance.
He does have some great memes on his Doc Mills page, so you can check those out. But Will, thanks so much for coming on. I think
Yeah,
this will
man.
be
Thanks for having me.
very insightful to a lot of people, and I'll put those some resources there in the show notes for people as well. So,
Cool.
thanks for listening in, everybody. See you next time. I'm the worst at sign offs.